video is brought to you by Dr. Barai. Please press on the subscribe button and the bell icon.
Hello everyone, this is another video on ECG Made Super Easy. In this video we'll discuss about an interesting ECG that we have found in Twitter, and this particular ECG is based on the third degree heart block. My name is Abhijit Barai, and I have with me Becky, who has got some really interesting interpretation skills of ECG. She has got some good knowledge and understanding of the ECGs, and she's going to help me in interpreting the ECG and making this presentation. Welcome, Becky.
Hello everyone. I am Becky. As always, I am very excited to be here. Over the next few minutes, we are going to show you some awesome ECGs with a lot of animations and up-to-date information. Hope you like it. I know how amazing you are. Please press on the subscribe button below and do not forget to click on the bell icon to get regular updates. We will bring to you new exciting videos regularly for your education and entertainment. If you have any burning questions or awesome ideas, please write in the comments section below and we will get back to you as soon as we can. I can assure you that the next few minutes will be brilliant. I will be with you till the end of the video. Let's start, shall we?
Yeah, sure. So let's show you the ECG at first. So what I will suggest is press the pause button and go through the ECG in a very systematic way, and then once you are finished, then you can press the pause button again, and we will interpret this ECG together. Now, I'll have to be very honest, this is not a 12-lead ECG, this is just a rhythm strip. There are two leads here, this is lead 2 and this is lead 1. So, Becky, would you be happy to interpret this ECG for us? Thank you very much.
It is a fantastic ECG, Abhijit. Thank you.
No worries.
I am going to interpret this ECG in a very systematic way. However, if there is an elephant in the room, that does not need an introduction.
Yep.
The elephant in the room in this ECG is a heart block. I will come back to it in a second. Let me talk you through the usual stuff at first. First of all, this is a rhythm strip ECG. Therefore a lot of information is missing that we look for in a 12-lead ECG. In this rhythm strip, the atrial rate is about 100 beats per minute while the ventricular rate is about 40 beats per minute. The rhythm is regular rhythm. I am unable to assess the axis from the rhythm strip. The P wave is normal in morphology. Interestingly, the PR interval is not constant. Actually, there is no correlation between the P wave and the QRS complexes. This is suggestive of a third-degree heart block. The QRS complexes are narrow. The ST segment is isoelectric. I would like to re-emphasize that I do not have enough information about the ST segments in the rhythm strips alone. The T wave looks normal to me. The QTC is about 480 milliseconds, which is in the upper end of normal. The AVR lead is absent in this rhythm strip. Now, to compile all these information together, I am of the impression that the patient has a third-degree heart block. With the QRS complexes being narrow, it is highly likely that the block is at the level of the AV node or nearby. I am particularly concerned about this patient. My immediate action would be to obtain a 12-lead ECG. Obviously, as a clinician, my role would be to seek and treat the underlying cause. For example, the third-degree heart block can be due to drugs like beta blocker or myocardial infarction. The cause needs to be identified and appropriate action need to be taken immediately. This is a bread and butter ECG for any emergency medicine doctor. Really impressive findings. Hope the patient is doing all right.
Yeah, that is a very comprehensive interpretation of this rhythm strip. Thank you very much. So yeah, absolutely. So there is a P wave, there is a P wave, there is a QRS complex. Probably there is a P wave hidden somewhere here. Then there is a P wave here. Another P wave is hidden somewhere here. Then there is a P wave. Now if you look at the PP interval, that can predict that there is a P wave here, and the PP interval is pretty constant, and the atrial rate is about 100 beats per minute and the ventricular rate is 40 beats per minute. There is a P wave here. With regards to the axis, I believe that this patient probably has got a little right axis deviation, because in lead 1 there is predominantly a negative deflection, and in lead 2 there is predominantly positive deflection, so it goes in favor of the right axis deviation. But again, it's very difficult to say without looking at AVF and lead 1. So I agree with all the findings that you have mentioned. That was really good. So let's get into the details about a little bit of deeper understanding of this complete heart block. So what is a complete heart block? A complete heart block is when there is a complete dissociation between the atrial activity and the ventricular activity, and I'll show you some animations to understand those concepts. So there will be no correlation between the P wave and the QRS complex. So P wave will appear in constant intervals, and QRS complexes will appear in constant intervals, but there will be no relationship between the P wave and the QRS complex, and that is all about atrioventricular dissociation or complete heart block. Now, what is an ECG? The ECG is the electrical activity which can be represented in a graphical way by the computer or by the printer. So normally there is some electrical activity in the heart which is very small in voltage, that can be picked up from the surface of the body by the electrodes, and then the computer can magnify it or amplify it, and then give us some picture either in on the paper as a printout or on the screen, and this graphical presentation is the ECG. Now please don't get confused between the lead and the electrodes. A lead is the specific point of view of the electrical activity of the heart. For example, if I say lead 3 or lead AVF or lead 2, that means what is happening to the undersurface of the heart, but there is no electrode on the undersurface of the heart or the body. So please don't get confused between the lead and the electrode. When we look at the ECG, we talk about the lead, not the electrode. Now conventionally there are 12 leads, and that will give you some 12 point of view of the heart. So we can look at the heart from 12 different angles to identify exactly what is wrong and where it is wrong. So normally there are 12 leads. There are 6 chest leads, V1 to V6, and 6 limb leads, lead 1, 2, 3, AVF, AVL, and AVR. Now in addition to that, you can get more leads. For example, if you want to know what is happening to the right surface of the heart, like in case of a right coronary artery infraction or right ventricular infraction, you can do a V4R. To know what is happening to the posterior surface of the heart, you can do V7, V8, and V9. In the case of the complete heart block, we can use these Lewis leads, where lead 1, 2, and AV 1, 2, and left leg electrodes, they are separated and they are put in front of the sternum, side of the sternum, and the right costal margin, and that will give you some idea if there is any atrioventricular dissociation. So to know if the patient has got atrioventricular dissociation, you can do Lewis leads. Now let's have a look at these animations to understand exactly what is happening to the heart in a normal heart at first, and then we'll go to the complete heart block in our patient. So this is the right atrium here, and this is the right ventricle here, sorry, left atrium here, and then this is the right ventricle here, and this is the left ventricle here. This is the tricuspid valve, this is the mitral valve, and then there is the aortic valve here. The yellow bits, this is the conduction system of the heart. The SA node is here, which is the pacemaker. Then there is the AV node. Then there is a bundle of his. These 3 bits, these are called internodal pathways. This is the right bundle branch, and then this is the left bundle branch. The left bundle branch again has got 2 parts. One is the left anterior fascicle and left posterior fascicle. Then there are the Purkinje fibers and the ventricular muscle. So we are going to show you some animations, and Becky is going to explain the normal conduction system and normal ECG as well. The normal ECG will look like this, and this is the PR interval from the beginning of P wave to the beginning of QRS complex. Please don't get confused between the PR interval and PR segment. PR segment is from the end of P wave to the beginning of QRS complex. So this portion from beginning of P wave to the beginning of QRS complex, that is PR interval. So Becky, would you be able to explain to us the normal ECG, how it looks like and why it happens? Thank you.
This is the normal cardiac activity. The SA node is the pacemaker of the heart. It generates cardiac impulse at the normal rate of 60 to 90 beats per minute. The cardiac impulse then passes through the interatrial pathways to the AV node where there is some delay. You can appreciate it here. In the ECG, there is a PR interval due to the AV nodal delay. This is followed by the conduction of cardiac impulse through the bundle of His into the right and left bundles and Purkinje fibers and cardiac myocytes. In the ECG, the P wave represents the atrial depolarization, the PR interval is the AV nodal delay, the QRS complex is the ventricular depolarization and the T wave is the ventricular repolarization. This goes on and on and on. So, the normal ECG is very easy to comprehend. One thing needs to be remembered is that the positive deflection of the ECG means that the cardiac impulse is passing towards the lead. On the other hand, a negative deflection means that the cardiac impulse is passing away from the particular lead. Excellent stuff, isn't it?
Absolutely. So this is the normal ECG. So this is not interatrial pathway. This is called internodal pathway, these three. But if you can understand this normal ECG, then it will be very easy to understand the complete heart block. That is what is happening to our patient. So let's have a look once again. So this patient this time has got an MI and has got a block somewhere here because of the involvement of the coronary artery and necrosis of the cardiac muscle here. So what will happen is that the SA node is producing cardiac impulse, but because of the damage to this conduction system here, cardiac impulse cannot go any further. But this conduction system in this part that has got the automaticity, it can generate the cardiac impulse on its own, even if there is no cardiac impulse coming from the pacemaker. So what is happening is that from the lower part of the bundle of His, distal to this block area, cardiac impulse is generated. Now a few things you can find here. First of all, the SA node is producing cardiac impulse, so there will be a P wave, and the P wave is coming at a constant rate around 100 beats per minute. If you look at the cardiac impulse which is generated from the bundle of His, that is appearing at a slow rate around 40 beats per minute. There is no correlation between the atrial activity and the ventricular activity because of the block here. So the P wave, it will be appearing in its own pace, and the ventricular activity, that will be appearing in its own pace. No relationship between the P wave and the QRS complex, and that is all about a complete heart block. Let me show you what happens to the ECG once again. So in this particular ECG, the same ECG that I have shown in the very first slide, that there is a P wave, and which is normal morphology, which is great. Then there is a QRS complex because of the QRS complex because of the depolarization that is generated from here, and this P wave is because of the cardiac impulse that is generated from the SA node. If you look at it, the PP interval is pretty much constant, and the RR interval, that is also pretty much constant, but there is no relationship between the P wave and the QRS complex because the PR interval, that is all irregular. So if you find an ECG where the PP interval is constant, the RR interval is constant, no relationship between the P wave and the QRS complex, and the PR interval, that is all irregular, that is a complete heart block or a third degree heart block. Now I am deliberately using the term heart block rather than atrioventricular block, because as we have shown in this picture, the block is not at the level of the AV node. The block is distal to the AV node. If it is in the AV node, you can call it AV nodal block, third degree atrioventricular block. But in this patient, this is not happening in the atrioventricular node. This is happening down the atrioventricular node. So ideally it should be called an heart block rather than atrioventricular block. But some people can argue that, well, this is the block between the atria and the ventricle, so we are calling it atrioventricular block. That is absolutely justified. Personally, I prefer to call it a heart block rather than atrioventricular block.
That makes sense. Thank you.
Yeah, so that's a very simple animation. The real complete heart block is much more complicated. There are a lot of fine details about it, but to understand the very basic complete heart block, that's the best animation that I could get. Now, every time you look at the ECG, please go through this in a very systematic way so that you don't miss anything, because complete heart block can be missed quite easily. So the first thing we suggest is look at the rate. When I say rate, I mean both atrial rate and the ventricular rate. So count the P waves and count the QRS complexes. If there is no correlation between them, the rate will be different. Right? For example, in our patient, the atrial rate was 100 beats per minute and the ventricular rate was 40 beats per minute. So look at the rate and look at the rate of the P wave and the QRS complex separately. After you are happy with the rate, then you look at the rhythm. Is it regular? Is it irregular? When you look at this 12 lead ECG, in the rhythm strip in this particular patient, we have seen that the P wave, that is pretty regular. The QRS complex, that is pretty regular, but again there is no relationship between these two. The third thing we suggest is look at the axis. For axis, the best thing is to look at lead 1 and AVF, which is absent in this rhythm strip, but still I feel that this is probably right axis deviation in this patient. Next we look at the PR interval. When we look at the heart block, either first degree, second degree or third degree block, then PR interval will give you the most valuable information. In this particular patient, the PR interval was irregular. So sometimes it is very long, sometimes it is short. That is because there is no correlation between the atrial activity and the ventricular activity. Again, please don't get confused between the PR interval and PR segment. PR interval is from the beginning of P wave to the beginning of QRS complex, and PR segment is from the end of P wave to the beginning of QRS complex. They are not same, they are different. You will get a lot of information from looking at the QRS complexes. As we have mentioned earlier, that in a complete heart block, if the block is at the level of the AV node, there will be probably narrow QRS complex. If the block is down below the conduction system, then the QRS complex can be wide complex. This is not true for every case, but this is generalization. This is the overall picture, but that looking at the QRS complex, if it is more than 100 millisecond wide or more than 2.5 smaller square wide, then probably the block is in the lower part of the conduction system. In our patient, the width of the QRS complex is borderline. It is I'll call it a narrow complex. So the QRS complex is generated from the bundle of His rather than from the right bundle branch or left bundle branch. After we are convinced that our findings so far are supporting the diagnosis, we can go for some more features like ST segment. If there is ST depression, ST elevation, that can give us some idea that it may be because of myocardial ischemia or myocardial infarction. It can also happen in case of digoxin toxicity like ST depression. So ST segment can give us a very good understanding. Again, for ST segment, you need to look at a 12 lead ECG. A 2-lead rhythm strip may not be the best place to look at the ST segment. And after that, we have looked at the QTC in this patient's ECG, and the QTC normally 350 to 450 milliseconds. If there is prolonged QTC, a lot of things can happen. It can be because of hypokalemia, hypocalcemia, hypomagnesemia. It can happen because of myocardial infarction. It can happen for electrolyte abnormalities, hypothermia, a lot of different causes of prolonged QTC. There are different drugs that can cause prolonged QTC. Even erythromycin can cause prolonged QTC. Ondansetron can cause prolonged QTC. Not necessarily they will cause complete heart block though. After we are happy with that, we'll look at the special things like AVR. Now in this particular rhythm strip, AVR is absent, so we cannot make any comment about that. So once that is done, we will go through the overall picture. We will get the information of the patient, symptomatology, we will get some blood results, we will do the 12 lead ECG, and then we will find out exactly why it is happening and what we can do about it. So that is the synthesis of this overall ECG interpretation.
Awesome. Really interesting.
Yeah, so looking at the ECG in a very systematic way can be very interesting, and it is very informative. It can give us a lot of information. Now very quickly, some of the causes of the complete heart block, why it is happening and what we can do about it. Now there is a mnemonic, probably you have heard about it, DIMES, D-I-M-E-S. So first of all, D for drugs. For example, if the patient has got beta blocker, calcium channel blocker, digoxin, these drugs have got negative chronotrophic effect, and so they can cause blockage of the conduction system that can lead to the atrioventricular block, complete atrioventricular block, or complete heart block, or third degree block in that matter. A very common cause of the complete heart block is myocardial ischemia. It can lead to myocardial infarction, and sometimes also it can cause inflammation like myocarditis that can cause blockage of the conduction system. Mechanical causes, for example, myocardial fibrosis. Usually in those cases, complete heart block does not happen overnight. They can have a long process of this myocardial fibrosis to cause a complete heart block. A common electrolyte abnormality is hyperkalemia. They can cause complete heart block. They can cause prolonged QTC. They can cause a lot of abnormal things. We need to keep an eye on the electrolytes if we find a complete heart block. There are some structural conditions. For example, if there is increased vagal tone for some reason, if the patient has got dissociation toxicity, or if the patient has got profuse vomiting, for some reason, if there is increased vagal tone, that can cause complete heart block. Sarcoidosis, Lyme disease, amyloidosis, they can cause this problem as well. Not very common, but this can happen. Now, the management. The most important part of the management is to identify the cause, why it is happening. And in the last slide, we have talked about a few common causes. For example, if the patient is on a beta blocker, stop that beta blocker. If the patient has got dissociation toxicity, give dizimind. And the definitive treatment of the complete heart block or third-degree heart block is pacemaker. And that is when we need to get the cardiology input. And usually these patients should not go home. They need admission to the hospital. They might end up having a pacemaker. Now, in summary, when there is atrioventricular dissociation, that is, patient develops a third-degree heart block, and rhythm strip may not be the best place to have a complete evaluation of the ECG. We need a 12-lead ECG to get a good picture about this condition. Once we identify the underlying cause, it becomes easier for us to treat that condition. So that's all about the complete heart block. Now there are a lot of information that you can get about it in UpToDate. In Life in the Fast Lane, they have got some few ECGs. This particular ECG I have taken from Twitter by Medical Exam Prep. They've got a lot of interesting Twitter input, and I have got quite a few interesting ECG and other materials from their site. Once again, thank you very much for watching this video, and if you've got some interesting ECG, please send us to us, and we'll be happy to make some new videos on your ECGs, and we'll have some more animations and a lot of discussion about it. Once again, thank you everyone for watching this video, and I look forward to seeing you all very soon. And thank you particularly Becky for interpreting the ECG in a very systematic way. I hope that everybody does the interpretation of the ECG exactly the same way you have done. That was absolutely fantastic. Thank you very much.
Okay folks. Thank you for watching the video. Hope you have enjoyed the video. You are so awesome. If you find it useful, please like the video, subscribe to the channel and share it with others. Please write comments below the video. For every comment that you write, positive or negative, I will personally give a cookie to my cat Lucy. I promise I will do. If you have any burning questions, constructive suggestions or some awesome ideas, please get in touch. We would love to hear from you. Your comments and suggestions are very important to us. You can contact us through email, Twitter or Dr. Barai's webpage. Thanks once again. See you soon. Bye for now.